We're live. Welcome, everyone, to another live session with the Cohen Center for Recovery from Complex Chronic Illness. If you've been watching for the last few months, you should know us by now. Hopefully, you do. But if you don't, my name is Dr. Raven Baxter. I'm the Director of Science Communication at CORE, and I am joined by David Petrino, who is the Nash Family Director of CORE, Dr. David Petrino, and Dr. Amy Prowell, who is the Scientific Director of CORE. And today we are gathered here to have a conversation about neuroinflammation in the context of infection-associated chronic conditions, IACCs. And it is a very broad topic, but we're hoping to answer some great questions today. If you have any questions, please leave them in the chat. I see some people have already gotten engaged, and that is what we're here for. We love two-way conversation. We're here to learn with you and share knowledge with you. So without any further ado, let's talk about what neuroinflammation actually is. This might be new to some people, but it is referring to the inflammatory response that occurs within the nervous system, which I'm sure you probably gathered from the name itself, particularly in the brain and the spinal cord, though. And neuroinflammation can be initiated by different triggers. Of special interest to our center is how infection can trigger neuroinflammation, but also brain injuries, like traumatic brain injuries, can trigger neuroinflammation. Toxins in the body can cause neuroinflammation, and also autoimmune reactions can cause that too. So in the context that we're interested in looking at this in is IACCs, and neuroinflammation plays a significant role in the pathology of several complex chronic illnesses that we study at the center. So Amy, can we talk a little bit about the key players in neuroinflammation, specifically glial cells, and what do they do for our brain, and what happens with IACCs?
Yeah, well, so, a number of immune cells can either, sort of penetrate into the central nervous system and activate and in a sense cause neuroinflammation. But one that is studied the most in that capacity exactly are microglia. They're the brain's resident immune cells. And they are, again, normally part of the brain's immune system that responds to, whatever the brain needs to do related to immunity. So, for example, if an infectious agent or some other, external factor is able to permeate into the brain or sometimes the spinal cord, depending, microglia will activate, recognize it, and then, like any immune cell in the body, usually try to mitigate it and deal with it, right? So in the context of neuroinflammation, though, what is usually happening is that the immune cells like microglia, they become activated. And so the reasons for that can be, different. It's supposed that microglia can become, for example, activated, I don't know, in and of themselves. Like, there's always like just sort of inflammation where I guess the glia could activate that way. But the truth is, part of what we're studying in infection-associated chronic conditions like long COVID or even tick-borne, vector-borne illness is what factors cause these microglia immune cells in the brain, in the central nervous system, to activate and in a sense often become perpetually active in a way that causes them to drive inflammation in the brain. And, those could be infectious factors. They can also be other, environmental factors, which is an interesting thing to consider. I think one thing to understand about microglia in the context of inflammation is that they can become primed. It's an important part of the way that they drive neuroinflammation when they do so. And what happens is one factor can activate a microglial immune cell and cause it to be in basically a new state where it's now it's primed. And what happens is another factor, maybe this is an injury or an infection or some other hit that could activate microglia as well, might now also activate that microglia. And because it's in this prime state, the response it has to sort of this second factor sometimes is actually bigger than the response it had to the first. So there can be sort of a collective priming by which each factor that stimulates or activates microglia that can sort of, their collective activation can contribute to or drive neuroinflammation, can become sort of sequentially primed in a way that can sort of build up to the ultimate neuroinflammatory state. So that's part of it.
Yes, thank you, Amy. I want to break down a little bit about what activation means, just so people can follow along in case they might have not been sure about that. But activation um, is referring to the specific cells in the brain's immune system, how they respond to problems like infections, injuries, harmful substances. The activation itself is a crucial part of what neuroinflammation is. It can play a significant role in both protecting the brain, but also it can cause harm. So immune cells, they'll recognize a threat. And so microglia, astrocytes are immune cells that can recognize problems. They're constantly monitoring the environment, looking, detecting signs of danger, like, okay, pathogens or viruses. Are there damaged cells? Are there toxins? And then when they detect that, they can become activated and then they respond. So how they respond is they can change their behavior. Um, Microglia can shapeshift a little bit. They can change shape. They can become larger. They can mobilize. They can extend themselves to reach places that are damaged and engulf debris. And then astrocytes can also change their shape and release signaling molecules that can increase that inflammatory response or the immune response, or help repair some of the damaged tissue. And the way that they do this is through substances called cytokines, also chemokines. And that's basically how cells kind of talk to each other for the most part. They're signaling molecules that help coordinate this immune response. The protective measure of this is activating immune cells is, on one hand, it can protect the brain, right? When they're working correctly, they can clear away the pathogens, they can clear away dead cells, they can promote healing and help to maintain that homeostasis and normal functioning. If there's a brain injury, microglia remove debris, they support repair, but then it can become harmful if they're activated for too long. And that can happen if there's like a persistent threat of inflammation. They can start to harm healthy brain cells. And if that's a chronic issue, that can lead to ongoing neuroinflammation, which can lead to like actual neurological disorders. So when we say activate, like it's one simple word, but there's so much more that goes into understanding the process and the impact of what it means, like when your immune cells in your brain are activating. So very fascinating. The brain is always a fascinating thing to talk about. If anyone has questions, feel free to ask in the chat.
And I could also go into like some of the findings on neuroinflammation. There's one study that was done by my colleague Mike Van Elziger, who works at the Harvard MIT Martino Center in Boston, and they used PET imaging, which is a form of neuroimaging, to look for microglial activation in the brains of patients with long COVID. And they're also doing the same study in patients with pre-COVID ME/CFS, but they haven't published the results yet. And in the long COVID study, though, what they found was interesting. They did find signs of neuroinflammation in the long COVID brain. Now, the way they do this, again, is that they take a participant and they put them in a scanner. So there's an imaging scanner, and the person, lays down in their, brain, and this is an imaging study where they image just the brain, because in some cases you can actually image the brain and spinal cord, but they were focused on the brain itself. And what they do is, the way that the imaging works is they inject what's called a radioligand into the participant. And in this case, the radioligand recognizes TPSO, which is a compound that's produced by microglia. So when microglia activate, into that state that can be characteristic of neuroinflammation. They release TPSO, which then can be sort of identified by the scanner as long as this radioligand that was injected safely into the patient sort of tags it for recognition to be imaged in the scanner. And so what they're able to do is get images then of the brain and where the TPSO was expressed in those regions where there's elevated TPSO are regions that show neuroinflammation. And so they did that in patients with long COVID, and they compared their brain scans to almost 20 scans from patients who had the exact same techniques done on them before the pandemic. And what they found is that in the brains of patients with long COVID, there was increased microglial activation, especially in regions that are associated with the blood vessels or the vasculature, often in regions that are either have gaps in the blood-brain barrier where potentially inflammatory factors from the blood could potentially permeate a little bit more into the brain, or in organs of the brain called that basically have fenestrations in them that allow them, again, to be more susceptible to potentially blood-borne factors. And because they saw this sort of what they called a vascular or blood vessel associated pattern in the neuroinflammation, they took blood that was obtained from the same participants who underwent the neuroimaging right before they'd gotten into the scanner. And in that blood, they measured a range of different vascular or blood vessel factors. This included fibrinogen, L-selectin, clotting factors, blood vessel factors. And they did find actually very strong correlations between many of these factors and the neuroinflammation, including fibrinogen, which was strongly correlated. So if you had neuroinflammation, you were very also likely to have fibrinogen. If you had neuroinflammation, you were also very likely to have L-selectin, for example, another vasculature-associated molecule circulating in your blood. In fact, L-selectin is a molecule that sort of impacts how immune cells bind to the blood vessels. Thus, if it's kind of increased, it suggests that there might be, again, issues with the way that the immune system and the blood vessels are interacting. So what part of their hypothesis is that potentially factors in the blood, for example, activated platelets, clotting, sometimes maybe influenced by the SARS-CoV-2 spike protein in patients, might be part of what is getting to the central nervous system or activating regions of the central nervous system that are really susceptible to that inflammation, meaning that what happens in the blood vessels of these patients with long COVID is likely, at least based on this first published finding, part of the neuroinflammatory process.
And so I would guess that since the brain is basically just this giant computer, it would matter where the damage is occurring. So what do we know about, is the damage localized to particular areas of the brain? And is that localization tied to any specific symptoms that we see in the patients?
Yeah, I think there are many paths to neuroinflammation, as Amy was pointing out, mechanisms behind neuroinflammation are many and varied, and certainly work that we published with Akiko Iwasaki and Michelle Mongi's team at Yale and Stanford respectively, we were able to show that when you infected mice very specifically with a respiratory form of SARS-CoV-2, which did not leave the lungs of the mice. So they had very mild illness that didn't leave their lungs. There was still, CCL11, which is a chemokine, Raven, which you mentioned, these chemical mediators. CCL11 was, being produced, circulating in the body and causing white and gray matter damage and microglial activation in these mice. What we also did in that particular study was we showed that CCL11 was overexpressed in humans who had long COVID, who also reported cognitive impairment along their symptoms, indicating that chemokine release that is triggered by something like SARS-CoV-2 can lead to neuroinflammation. In addition to that, so that's one way you can get neuroinflammation. Another way you can get neuroinflammation is mast cell activation syndrome. So, as Amy was mentioning with, endothelialitis, one of the things that happens when the endothelium becomes inflamed is that mast cells, which are these immune cells that are present everywhere, but are also heavily present in the endothelium, they degranulate, and meaning they start to release all of these inflammatory mediators, such as histamine. Histamine will directly act upon nervous tissue. They'll directly act on white matter and gray matter and start to cause inflammatory release in nerves. And so that's another way that you can have a systemic response that leads to neuroinflammation and cause all sorts of problems. Then, I think that we've discussed this, multiple times across multiple of these sessions, the idea that persistent pathogens can hide in neural tissue. Now, when you start to think about persistent pathogens hiding in neural tissue, or maybe digging into a nerve, such as the vagus nerve, and slowly making its way up to the brainstem, that's when we can start thinking about neuroinflammation, but neuroinflammation that is a little bit more targeted to a specific area. So when we're thinking about systemic inflammation and systemic neuroinflammation, so things that are caused by MCAS or things that are caused by proliferation of chemokines and cytokines as a result of a systemic inflammation, a systemic infection, and thereby inflammation, everything tends to get affected. But often what you'll see in terms of symptoms is that the areas of the brain that require the most in terms of energy and resources tend to get affected more more strongly, because they're kind of your canary in the coal mine, that like resources are starting to get tight. Because let's not forget, inflammation causes mitochondrial dysfunction, which leads to energy crisis, and so all of a sudden you can have situations like mood disorders starting to occur, loss of executive function. So people will have a harder time controlling emotions. They'll have a harder time forming plans. They'll have a harder time with like high-level orders, like something that we call praxis. So it's like, praxis is being able to carry out different steps of a task. So, I want to make a cup of tea, so I know that I get the cup and then I boil the water, and then I, get the tea bag, put the tea in there and add the water. A series of steps that to be in a certain order. You start to lose the ability to remember the order of the steps and place them in the right sort of sequence in order for the task to be completed. So maybe you'll sort of put the tea bag on the table, then you'll like go start looking for a cup, and then you'll pour the water. You start to get very confused about what you're supposed to be doing when. And of course, one of our highest level functions is language. And so people with systemic neuroinflammation will often report language difficulties, finding the right word, being able to string sentences together coherently can be suddenly very, very challenging, which of course is extremely difficult and extremely scary. Then, we often see, sort of tearing down from there, we start to see, short and long-term memory issues beginning to occur, and motor incoordination. So maybe you start to drop things or become a little bit more clumsy in your actions. These are symptoms that are really sort of common and that can occur with neuroinflammation, especially on a systemic level. When we go more specific, so one of the areas that we think, and there's been a few papers out there suggesting that the brainstem and the thalamus and hypothalamus can get deeply affected by more specific neuroinflammation. That's when you start to get things like sickness behavior emerging. So this is, this general feeling of malaise and extreme fatigue and, difficulty even being able to wake yourself up as a result of neuroinflammation in the brainstem. This can also lead to hormonal dysregulation as the hypothalamus pituitary adrenal axis starts to get affected. So now your ability to produce hormones like testosterone and cortisol start to get affected, which then, as cortisol and testosterone start to get affected, inflammatory responses get even more dysregulated. So neuroinflammation and systemic inflammation can continue to sort of spin up and become more problematic. So, as you can see, I've said a lot just there. I just realized, but as you can see, that there's these processes in place that can really start to form unhappy cycles that our job is to both research, but also to find drugs and interventions that can break, because these are reversible, these are treatable with the right precision targets when we understand what's going on.
Right. And I wanted to add that exactly neuroinflammation doesn't always have to represent damage or irreparable damage. If you remember, like we're talking about immune cell activation, and it is possible that that activation occurs and so much cytokines and of those inflammatory proteins are sort of created that there could be some kind of permanent damage. I mean, that's not out of the question, but really, if you could either remove some of the factors that are causing the immune cells to activate, right? Let's say an ongoing infection or the stimulus of mast cells that are part of the inflammatory process. So if you can, tone that down or remove the factors that are causing the cells to activate in the first place, or calm down the cells themselves, and probably both those approaches, together, sort of removing the factors underlying the immune cell activation and kind of calming the immune cells down might even be most effective, then there is some hope that you could bring that neuroinflammation back down and modulate it, right? So that it wouldn't necessarily have to result in permanent damage, and you could potentially help the disease process and symptoms, right? So that is actually a really cool area to engage in on the therapeutic front. And I'll add too that there was one study done in ME/CFS patients where they used that same form of PET imaging that I mentioned in Mike's long COVID study, where they did find increased neuroinflammation in the brainstem, that area that controls a lot of autonomic function, the sickness behavior response, which is really the feeling of fluiness and malaise that happens when people have either, an infection or other inflammatory factors that just don't subside. They did find that in one study, although it was a small study and done out of Japan. So there are other groups, Mike's, but even others working to replicate that study in ME/CFS with PET imaging, which hasn't been done yet, because it would be very interesting and to understand if brainstem or certain specific regions are also sometimes activated in patients with some of the different infection-associated chronic conditions.
I think you both did a great job of concisely describing what could be a very complex topic. We do have some questions. I'm not, can you see them in the chat? Okay.
Yeah, where do we want to start? Do you want to pull them up, or?
Sure. So Amy, you mentioned that this neuroinflammation doesn't necessarily coincide with like damage per se, and that it's potentially reversible. So can we talk more about that and I guess what that entails?
Yeah, the truth is I'm not enough of a neuroinflammation expert to know what forms might be totally damaging or potentially reversible. So I'll punt that question to David in a second, but I did see someone's comment about what about spike binding to H1 receptors, triggering MCAS next to spike, influencing blood cells. And yes, that's totally possible. I mean, one of the findings that enough groups in the long COVID field have found is that a portion of patients with long COVID, at least depending on the technology used in the study, depending on how sensitive it is, because you have to have tools that can find small amounts of viral protein, but are finding SARS-CoV-2 proteins like spike or sometimes even S1 in the blood of patients with long COVID, sometimes years after initial illness. And the spike protein can do a lot. I mean, the spike directly, can seed, in a sense, clotting type processes it can directly infect the blood vessel. The virus can, and the spike can directly sort of drive inflammation associated with the blood vessels. Spike can also activate platelets, which we see activated in long COVID. Some of those factors in Mike Balzer's long COVID study that were activated in the blood all could be impacted and more likely to be there if the spike protein was there, is the truth. So there could totally be that relationship. About spike binding directly to H1 receptors certainly seems possible. And in fact, MCAS, which is the activation of mast cells, often happens in the context of an uncleared infection or an uncleared antigen, which is a protein, where the failure to clear that pathogen or protein, all it causes mast cells to come in, because mast cells are some of the most basic cells of the immune system that will always try at least to seek out an uncleared infection or uncleared protein from any pathogen and keep activating in order to respond and attempt to address that threat. But if they don't succeed, they just become, kind of perpetually active, which is basically what's seen in MCAS. So while it doesn't have to be the only factor affecting MCAS, definitely spike sort of binding to an H1 receptor, triggering MCAS next to spike influencing blood cells seems possible to me.
Yeah, totally agree. And with regard to the reversibility question that was placed in the chat, to Amy's point, I mean, I think it's challenging to say with certainty when it comes to neurological injury and neurological repair, what's perfectly reversible and what is something that can be rehabilitated or adapted against. In terms of reversibility of the neuroinflammation itself, I would say initially our goal should be manageability, not reversibility. We're not trying to, at this point, we're not clever enough in our drug targets to be able to sort of like reverse the mechanisms that are causing the neuroinflammation. We're at our sort of infancy of managing these sort of things in a sophisticated manner. But with the right combination of medications and interventions, there is a possibility that we can manage neuroinflammation so that it is not causing either minor recoverable damage to the nervous system or major damage to the nervous system, and that we keep neuroinflammation under control. The silver lining, or the sort of bright spot, I suppose, in terms of the majority of neuroinflammation that is observed in people with IACCs is that it does not, in the short term or even in the medium term, appear to affect structural brain integrity. So we're not seeing changes to brain morphology as a result of neuroinflammation as you would in a traumatic brain event, such as, a hemorrhagic stroke or, any other incident that causes severe brain damage as a result of, severe acute inflammation. So what that tells us is, although the neuroinflammation is making you symptomatic, it's not causing the sort of structural changes that could be completely irreversible or very, very difficult to rehabilitate, which again points us toward the need for management strategies, and which to the next question, which I really appreciate all of these good questions that are coming from this user on X, from Unite to Fight. It seems like I would also say that I would refer to the clinical trial strategy that I laid out in a Polybio symposium, I want to say 2023, about how we should be thinking about trialing for different drugs regarding to different symptoms related to IACCs, where we should be thinking about trialing lots of different drugs quickly and working very, very hard to deeply phenotype responders and non-responders so we can understand this. Let's pull one drug out of the hat, famotidine, which in placebo-controlled RCTs has been shown to improve cognitive impairment in people with long COVID by being a histamine blocker. So a histamine receptor blocker. So it blocks the ability of histamine to bind to neural tissue and cause subsequent inflammation. Not everyone responds to famotidine, but many people did. Enough people did, in fact, to make that a successful placebo-controlled RCT. So what we want to really try and understand is what is happening in the blood and the tissue of people who are responding to famotidine, so that we can test for that before prescribing famotidine. And if we're not seeing it, we then move on to the next intervention, which might be something like low-dose naltrexone for neuroinflammation. And then we move on to the next intervention, which might be a combination of mast cell stabilizers with an H1 blocker and an H2 blocker. And the only way to get this is through rapid but very, very targeted initial interventional trials, moving on to larger adaptive platform trials that trial multiple interventions all at once, so that we can really zero in on combination therapies that help.
Speaking on treatment, David, I'd like to pivot toward assessment as well, because as someone who has experienced neuroinflammation, it can be very alarming depending on how that manifests. And for me personally, the biggest manifestation of that was panic, anxiety and panic, whereas previously to being infected, I had never experienced any, anxious or like anxiety disorders or any type of panic disorder. And then after I was infected, in the months and even years after, I've had various levels of panic that have ranged from severe, where I'm in the emergency room, to, just near baseline anxiety, but still heightened. And being that this symptom in particular is overlaps with a lot of other causes and drivers of chronic illness, and also other, infections that aren't long COVID or the SARS-CoV-2 infection. How, if someone is coming to you with a presentation of like me, where the main symptom is panic, how do you approach that? I've had a lot of people reach out to me individually saying, I've been infected and I've not been the same. I really struggle with my mood and depression, anxiety, and like, what do I do? So how do you assess? What are the steps, I guess, to assess someone from that standpoint? And how do you treat that?
Yeah, this is a really important question. And again, I think that whenever we see someone coming in with a new case of IACC, where we want to try and understand a full history of what's going on, because everything always starts with listening to the person who's in front of you, listening to their story, understanding things from their perspective. So one of the first things that we want to try to do is understand that, are these feelings entirely new? Are these feelings something that were triggered by the infection? Or are these things that are, that were pre-existing that are now just, significantly worsened by the fact that you're experiencing a complex chronic illness? So the first thing is, when did they start? Really trying to sort of dig into that. The next thing is trajectory, right? Are they escalating? Are they dialing down? Are they staying the same? And the next thing from there is trying to understand what are the sorts of activities or things that will make you better or worse. So for instance, we often hear from people with neuroinflammation and neuropsychiatric symptoms associated with neuroinflammation that eating certain foods will place them into a situation where their symptoms are much, much worse, and their feelings of anxiety and panic are, through the roof. And that's because they're eating high histamine foods that are then sort of leading them into this like inflammatory cascade that suddenly, it sounds so ridiculous, but there are people out there who will tell me about like feeling high off of having hot sauce or peppers or tomatoes or eggplants, and that is because nightshade vegetables are super high in histamine. And so yep, absolutely, you can get this sort of buzzy high if you're sensitive to histamine from eating these foods. So really this is where it comes down to like a bit of a detective process of like, okay, what's happening with your diet, what's happening with your sleep. A lot of people with long COVID and other IACCs have significant sleep disruption. One of the things that I was talking about online, and one of my colleagues, David Joffe, who I speak with a lot, who's a sleep physician, talks about dopamine senescence in people with long COVID, meaning that their brains have less dopamine than healthy controls. Dopamine is a neurotransmitter that we often see in what has many roles. One of the roles is, believe it or not, reducing inflammation in the brain. Other roles associated with dopamine are, movement initiation and motor system performance, which is why it has such a prominent role in things like Parkinson's disease. But when you're not sleeping enough, you can have or you're not getting restful sleep because of sleep disruption, you can have depleted dopamine, which again can lead to neuroinflammation, which again can lead to some very, serious and unusual behaviors emerging within you that might be coming on, but you can't really do anything about it. And it can follow a night of more severely disrupted sleep. So therefore your, dopamine levels are completely depleted. Many other things can trigger these. So, understanding if you're working with a person who menstruates in your clinic, understanding how their cycle is affecting their symptoms, because to go back to MCAS, estrogen is actually a very is a hormone that really promotes mast cell degranulation and histamine release. And so in periods of the cycle where someone's where someone's estrogen is sky high, that can lead to significant histamine release, and this cascade of neuroinflammation and behaviors associated with neuroinflammation. So understanding where everything is coming from, taking a complete history, really taking the time to listen to who's in front of you and hear what they're saying, not just writing down, panic attacks and sending them off to psych, because that's not going to be helpful if some of these other mechanisms are at play. But also being mindful of the fact that, it can be extremely distressing to be suddenly diagnosed with a chronic illness. And if you do have a pre-existing, anxiety condition and it's getting worse, you do need to sometimes tap in psych or neuropsych to help with management alongside. But I think the main thing in terms of when we assess is trying to understand why these feelings are happening. What are the physiological processes that are happening alongside the feelings that are taking over when they're taking over. And then then we can do more, once we understand the history, really listening to the person, then we can start the assessments, then we can lead to treatments.
Thank you, David. And I feel like you're preaching to the choir here for some of those things. I'll never forget. It was probably about a month and a half after I had gotten recovered from an acute SARS-CoV-2 infection, and I was trying to eat, I couldn't, and I was just so frustrated because every time I would try to eat, my body would just completely just react, and I would be panicking. I tried to eat a cheeseburger, and after the first bite, even I couldn't finish because I was just going into overdrive and I couldn't get any food down. And that didn't help anything. You need food to eat. I couldn't sleep. I was seeing a psychiatrist at the time who fortunately was willing to work with me like as a team and was very much listening. And he said, well, the first thing we need to do is make sure you get your sleep, because if your sleep is not on track, then it's going to be really hard for us to address all of these other things that are going on. And so I can't stress enough how important sleep is. So anytime, any way you can get great sleep, and even if that just means looking at your sleep hygiene, you know, not being on screens late at night, if you can be on a screen, you know, lights low, and really just taking care of your sleep hygiene, that goes a long way. And take it from there. But I'd also say if anyone listening is experiencing this, be kind to yourself, because you might be experiencing a version of yourself that you haven't seen before. And so don't be too hard on yourself if you are suddenly not able to remember things, or you might feel sad, or you know, I couldn't drive for months because I would forget the steps to drive, like putting the car in, take it out of park, put your foot on the brake. So I like stayed home. You know, I just had to take time. It took a lot of time, a lot of grace, and self-care, and changing habits, changing my eating habits, sleeping habits. It took a lot of work. But I was able to get to a point where I had a decent quality of life. I still struggle with some things, but making sure that you understand that some of these things are out of your control and some of them are, and working with your caretaker to figure out a way forward is a path that you can take. So it's tough when your brain seems to betray you. One of the hardest things to lose is your mind. So I understand the struggle, and really glad to know that there are treatments that can help people resume a good quality of life.
Yeah, absolutely. And I think we might, I mean, thank you so much for sharing that, Raven, because I agree that I think of what everyone, of all the symptoms that people relay to me, you know, the most fear is associated with the cognitive symptoms. I think it's kind of drummed into us that if something's happening to your brain, it's permanent. I think that it's drummed into us that, like, you know, like this is the part of us that is irreplaceable and you know and unchangeable. And so when we start to see things happening, there's this sort of like very strong fear associated with it. And you know, I hope that there is some reassurance here that although we take neuroinflammation extraordinarily seriously, you know, it's also possible to come back from it, and it's also possible that you know, we're working toward, you know, more and more effective interventions, and with the right interventions, quality of life can return. I think in a conversation of neuroinflammation, it would probably be remiss of us not to at least tip the cap toward PANS and pandas as well. I think that you know, we frequently, I think sadly we frequently miss out on a lot of conversations around pediatric conditions. PANS stands for pediatric acute onset neuropsychiatric syndrome, and pandas stands for pediatric autoimmune neuropsychiatric disorder associated with streptococcal infections. So when we talk about infection-associated chronic conditions, and we're thinking about PANS and pandas, this is, you know, often a very confusing and upsetting diagnosis for parents, as well as, of course, for the children who are being diagnosed. But often the way that pandas will present is, you have a young kid who is fairly healthy and, hasn't had a significant medical history. They develop strep throat or some sort of bacterial infection, and it leads to the emergence of obsessive compulsive disorder like symptoms. So a child would go from having no significant neuropsychiatric history to suddenly having very significant OCD-like symptoms. At this point, often and there are other symptoms as well. So there will be aggression, there will be emotional ability, there will be a lot of behavioral problems suddenly occurring in a child that had no prior history. Thankfully, pandas is starting to get more and more recognized as a very severe and serious condition that requires treatment with antibiotics to address the pathogens that are infecting the child. But for the longest time, and still continuing to this day, we see a lot of minimization. We see a lot of referral to psychology, a lot of sort of diagnosis with OCD or depression or some other associated psychiatric diagnosis that has nothing to do with what is actually occurring in the child. And I think that it's a really good example of how extremely profound behavioral sequelae can occur from an infection and be subsequently cured with the right intervention if the diagnosis is made in a timely fashion by a skilled and informed clinician.
Thank you, David, for talking about pans and pandas. I just want to acknowledge we have 1,230 viewers right now. And I would like to just reiterate that we are welcoming questions. We have 10 minutes left to share with you all today, and we want to make sure that you have an opportunity to participate in the conversation, to ask any questions about neuroinflammation. If you have questions about what anything means or questions about research. I see we have a comment that says, is worry about post-exertional malaise part of the disease or something that needs attention, challenging pacing efforts?
Sorry, let me try and digest that question. I'm feeling a bit confused by it, but
I think I know.
Oh,
I think I
go
understand.
ahead, Amy. Sorry.
Patients with long COVID, often ME/CFS. In fact, it's part of the ME/CFS, most ME/CFS diagnostic criteria, and even tick-borne, vector-borne illness often suffer from what's called post-exertional malaise, PEM for short, which means that if you in the moment, a lot of people can push themselves somewhat physically or cognitively. So they can go get up and do something or use their brain a little bit. But then 24 or 48 hours later, they crash from even that small amount of activity. And so there's this delayed response, this post is essentially like post from when the exertion occurred response, where they can really crash and feel much, much more worse at that later point in time. And what that means is that patients who have PEM have to be always just extremely careful about what they do, because you have to start to understand, like, if you push yourself too much doing something in the moment, which is very tempting to do, because of course everyone wants to live their lives and or sometimes has to be able to function for just basic reasons of trying to do activities of daily living. But if you overdo that, you can crash later. So patients have to understand and really learn, like, when they get to the point where they're going to trigger that PEM later and what triggers it. And part of how they do that is by learning how to pace. In other words, they almost space things out, or they slow themselves down deliberately so that they can say, well, yeah, I have to do these things, but I'm going to do them extremely slowly and stop and rest between each thing I do. And they're pacing so that they don't reach that point where they push themselves later into that really difficult PEM state. And so one of the things that can happen with that, though, is that it can seem like a person who has PEM is afraid to exercise or worried about it, when, in reality, usually what is happening is that the person wants to exercise or move. They're afraid of that legitimate crash later. So I think that fear of moving does not cause PEM. What causes PEM is overexerting yourself in a manner that leads to a crash. And this is well documented in the literature. There are studies of PEM which actually show that if you take a person with PEM and put them on an exercise bike challenge. So for example, you take someone, and it's a hard thing to do to this patient, but you put them on a bike where they exacerbate their symptoms. They will then later, after doing that challenge where they overpush themselves, they will crash later. And that has been documented in research studies. But again, it's not because they didn't want to exert themselves that people don't do this. It's because they are worried about the crash later. That being said, there are some ways that sometimes people do some extremely small forms of physical therapy or things just to push, to try to not remain completely bedridden under conditions of PEM. But that's a totally different story, at least in my opinion, from being actually afraid of exercise or anything like that.
Yeah, I'm starting to apprehend the question, so my brain's not moving so quickly today. But thank you, Amy, for picking that up, and I totally agree. I think that there tends to be this sort of argument around just because certain patients sometimes respond to therapy or they respond to some sort of movement in terms of treating certain elements of their illness. That means that we need to move all patients, and that's simply not the case. I hate the narrative of fear of movement. I think that anyone who has experienced being confined to a bed or having to use, or just being forced to not move for a period of time because of what movement or exertion will do to them, finds such a notion offensive. Of course, you're not afraid of moving. You suffer consequences for moving, and therefore you adjust your behavior accordingly. And so then when somebody tells you, hey, I can cure you, all you need to do is get on this treadmill and get moving, that's not going to be an acceptable response to, you're not going to respond well to being told that. And so I absolutely refute fear of moving as a narrative. I think that what we need to do to move forward productively is to understand that folks with long COVID and ME/CFS often have PEM, which is a completely different mechanism to autonomic dysfunction and POTS, which can benefit from exercise therapy, but it benefits from exercise therapy due to completely distinct mechanisms to PEM. And when you're treating POTS, when you're treating POTS without the encroachment of IACC, so let's say I've got a concussion patient, for instance. Concussion often ends in POTS. You treat someone who has POTS that is related to concussion completely differently from the way that you would treat someone who has POTS but also long COVID or also ME/CFS, because people who have POTS and also long COVID and also ME/CFS have often have significant PEM as well. And at all times, you need to be checking in with them. Hey, is the exercise therapy or, is the autonomic rehabilitation that we have prescribed here, is it triggering your PEM? And if it is, we're going to back it up so that we can still make progress with the autonomic rehabilitation whilst not triggering PEM. I think that is a nuance that is often missed.
Thank you, David. Well, we're coming up on time. We have 1,313 people in the audience. And thank you, all of you, for tuning in today. This was a great conversation. I learned a lot, and I always enjoy being here with you too. You can catch us next month. We will let you know when, but you can catch us on our social media accounts. We are now streaming on LinkedIn, YouTube, and Instagram. And this recording will be available on our YouTube channel under our live stream section. And you could watch this recording and previous sessions that we've had, as well as all of the other resources that we have available to you to learn about what we do at CORE and about IACCs. So thank you and see you soon.
Thanks, everyone.